morning. How are you all? Thank you. That sounds a lot better. So, again, my name is Stuart Schlossman. You're at an MS Views and News program. I want to thank you for being here. Tonight we have two speakers. We were originally going to have Jeff Siegel, but now he's not. No, he is going to be speaking, but he's going to speak second. And only because Dr. Khatri, who I've asked to come all the way from Milwaukee, he's got 2 hours to get back. And, you know, it's a long way to go and then have meetings and patients to see first thing in the morning. So we're going to have Dr. Khatri speak first. And Dr. Khatri, for all of you that don't know, he's the founding medical director of the Center for Neurological Disorders, the Regional MS Center, one of the largest MS centers in the United States, caring for, wow, over 4,500 patients. I applaud you. Dr. Khatri earned his medical degree from the Grant Medical College in Mumbai, India, and completed his residency in neurology at the Medical College of Wisconsin, where he continued as an associate professor of neurology until 1990, at which time he opened the Center for Neurological Disorders. You know, there's so much to say about this person, but I don't want to keep going on and on and on. I would like to have Dr. Khatri come up here. Let's get started with this program. And so, come on down, Dr. Khatri. He's going to keep it in the stand. Keep it in?
Thank you very much.
Thank you very much. Oh, my God.
All right, thank you, thank you.
History. We got history.
All right. So, I want to thank all of you for finding time to be here today, and I want to thank Stuart for inviting me here. When I first heard, when he first sent me an email, I didn't even hesitate. You know, Stuart is such a great guy. He has done so much for the MS patients, and he has, as you heard just a few minutes ago, what he has done, very motivational. So let's give him a big applause and welcome him to Wisconsin. Thank you very much. Thank you for what you do. So, you know, what I'm going to do is not show you too many slides today. We're just going to talk. We're going to talk about MS, and we're going to talk about symptoms. We're going to talk about how you can manage your MS, and then we'll have a lot of time for question and answers. So we'll have plenty of time. But, you know, I have been caring for MS patients for the last 45 years. And that was the time when we did not have any approved therapies. And I remember in 1993 when the first drug was approved, and that was beta-serol. And we have come a long ways. Now we have 14 approved therapies for relapsing form of MS. And this is unprecedented for any other medical condition. We have not had so many treatments approved for one disease in such a short time as we have for MS. So it's very, very exciting. And all of these drug therapies have made a big difference in the lives of MS patients. So, you know, the big question is, what is living with MS today? And I can say that MS patients now can lead a good life. They can achieve all the goals that they want to. And that is so because we have so many new treatments available. You know, I remember when I started out, when I was a resident, I used to go to, once a month, I will go to a patient's home and teach the family and the patient about MS. I would do that once a month. And then, you know, the patients, they would talk to each other and say, oh, Dr. Khatri is coming to my home this Saturday, so we'll see a lot more families. And it got to the point where we had to move somewhere else. So we got a church. And then we grew out of church. And then we used to go to a restaurant and rent out a huge hall. And this was in the 80s. And I used to see patients who would come in wheelchair, mostly, or with the walker. And now, when I give talks, I hardly see anybody using a wheelchair using a walker. Those who do come in the wheelchair or with the walker, they've been diagnosed in the times when we did not have effective therapies. So it's made a big difference, big difference. I tell my patients, MS is not what it used to be. We have made such tremendous progress. Not only that, we know which patients may not do as well with MS. So we can be very proactive. So for example, we have learned over the years, based on the trials, based on the research, based on the MRI, that there are certain prognostic features that would indicate that the patient may not do well. We used to be, about 10, 15 years ago, when I would diagnose somebody with MS, the first question, it's very terrifying. It's a scary, and patients remember the first time they were told that they have MS. It has a big impact. And they would ask, Dr. Khatri, how am I going to be in 5 years, 10 years, 15 years? How am I going to be? And I used to say, MS is unpredictable. We cannot predict how you're going to be. But that's not true anymore. We can predict now. And we can predict because we have prognostic features. So for example, if somebody gets diagnosed over the age of 40, may not do as well. Somebody who presents with tingling and numbness as their initial symptoms will do very well, as opposed to somebody whose initial symptoms are weakness. Somebody who gets the first attack and we treat them with intravenous steroids, and if they respond very well, they'll do better. But those who don't may not do as well. If somebody gets 2 attacks in a year, may not do as well. People with color may not do as well. And those patients, we want to be very, very aggressive in our management. Patients who have, when we look at the MRI scan and we can count the lesions, we can see the overall disease burden. And if they have quite a significant disease burden, may not do as well. If you do the MRI of the cervical cord or the spinal cord and we see some lesions, they may not do as well. So now we know a lot of characteristics about the patients who may not do as well. So how does that help us? So when the patient comes to me and newly diagnosed, and I look at all these features, I say, this patient, I want to be very aggressive from the get-go. It's going to be, I'm going to be aggressive in my management. I'm going to be very proactive in my management of this patient. So I pick the drug that I feel is going to give the best results. But not only that, we have now tools and biomarkers that tell us how the patient is doing with a given treatment. And nowadays, we do more frequent MRI scans. That's very, very important. The patients, when I had a patient today, and I said, it's been 2 years. Let's do an MRI. And she said, Dr. Khatri, I'm still paying my last MRI. I don't want another MRI. And I say, so I explain. And there are some organizations that do help with the payments of the MRI scan. But the MRI scan, if I do an MRI scan, and if the patient's clinically looking good, but if the MRI shows one new lesion that's quite apparent to me, and if it looks a little concerning for me, I want to change my therapy. Because 5 years from now, that patient may not do as well. So I want to change my therapy now. I don't want to wait until the patient gets worse. And that means the horse is out of the barn. And we all live in the Midwest. We know what that means, right? So we want to be proactive. We want to take steps now. So if the patients don't do well these days, I think the physicians have some role to play in that. Because nowadays, we have so many good treatments, so effective treatments, and we need to be aggressive in our management. We need to be proactive in managing the patient. So what does living with MS today mean? It means that MS is something that we can conquer. We can overcome some of the problems. We have treatments now that completely shut down the MS activity. They shut down the relapses. They shut down the MRI. And that's amazing. So in this day and age, we can totally take control of the disease. And that's very, very important. And I think you need to. If you're not doing well with your MS, if you feel you're not able to work through the whole day, if you're having relapses, if your MRI scan is not active, be aggressive. Participate in your care. Because, let's face it, you have the disease. And you're living with it day in and day out. You go to see a neurologist for 15 minutes, 20 minutes at the most. You need to take control. You need to communicate with your neurologist. You need to know what's your MRI like. What's your vitamin D level? How many of you know what your vitamin D level is? Raise your hands. Good, very good. And this is very important because research has shown that vitamin D is very, very important. When you raise your level to about 60 or 70, you can make an impact on the exacerbations or the relapses. Not only that, the incidence of MS in this country is 1 in 740. If a parent or a sibling has MS, then the incidence goes up to 1 in 4040. The only thing that we know will protect somebody from getting MS is vitamin D. So I tell all my patients, your brothers and sisters should take vitamin D. Your children should start taking vitamin D. And they can start taking very, very early, even in the first year. But it's very, very important. Under the age of 17, talk to the pediatrician. But over the age of 17, they can easily take 4,000 vitamin D3 every day. You want to raise your levels because that will protect. We know that for sure. Will protect them from getting MS. So I want to focus a little bit about understanding the importance of a comprehensive healthcare services or a healthcare team. Now, MS will strike anywhere in the brain and the spinal cord, right? It's a disease of the central nervous system. Your brain and your spinal cord control all of your bodily functions. And just think for a moment, if you didn't have your brain or your spinal cord, you can't think, you can't do anything. So MS causes multiple kinds of symptoms depending upon where the MS strikes. So MS patients can have cognitive issues, they can have depression, they can have balance issues, they can have weakness, bowel, bladder issues, spasticity, sexual dysfunction. So it can cause all of these problems. And therefore, your main neurologist may use services of other people. And we're going to hear from Jeff today, the importance of exercise, how important it is. But not only that, managing your bowel and bladder problems, managing your spasticity, managing your depression, all of these things are very important. And your neurologist may treat them, but it may come a time where he or she may need help of other specialties to come in and help out to get you the best care possible. So I'm going to talk a little bit about some of the symptoms and where we have made progress, right? So spasticity. This is very, very common in MS patients. And what I mean by spasticity is where they get tightness of the muscles, they get spasms, their legs jump out, and we have lots of medications available. But before that, we would do some of the stretching exercises. If that doesn't work, you go to the medications, and if that doesn't work, we go to what we call intrathecal baclofen pump. How many of you are familiar with that? Raise your hands. Right, not too many. Intrathecal baclofen pump. So what that is It's a pump like the size of a hockey puck. It has got a reservoir, and it's got medicine. It's an antispastic medicine. And there's a tube that goes directly into your spine where the medicine is delivered. And everything is under the skin. And there's a computer in the pump that talks with a computer outside. And we can regulate the dose that is to be delivered into the spine. So it goes directly where the spinal fluid is. And this is to bypass the blood system, so you don't get the side effects. It goes directly where it's needed. And the dose is very, very small. And it works like a miracle. It's one of the treatments in MS patients where I think it's godsend. It really makes a big difference in patients who have spasticity with the intrathecal baclofen pump. Bowel bladder issues are very common in MS patients. And let me explain to you a little bit about the bladder issues, how that works. So in a normal person, when urine gets collected in the bladder, and when there's enough urine in the bladder sends a signal to the brain. And it says, look, I'm full. Take me to the bathroom. And the brain talks to the bladder and it says, you know, Dr. Khatri is giving a great talk. Why don't you settle down? And when he's done talking, I can take you to the bathroom. Well, the MS bladder will talk back. And he says, I don't care who's talking. Take me now. If you don't take me now, I'm going to go now. You know, that's the kind of bladder we have in MS. And that's the commonest kind. There is a spastic. You know, it wants to go all the time. And they can have incontinence as well because the bladder spasms. Luckily, we have a lot of treatments available for the bladder issues. And that we can manage. And now we have Botox therapy that we can use for the bladder. They can help control the bladder as well. And it works very, very well. The bowel issues. You know, a lot of my patients tell me, you know, the bowels move when I don't want to. And it's very, very embarrassing. They have no control. And I tell them that, you know, we can control the bowels, but you need to tell the bowels who is the boss. You need to get a bowel prep. You know, you need to do that so the bowels know who's the boss. So, for example, what I tell my patients is that find a time in a day where you'll have enough time to sit on the john. You go and sit down and you try to go. If you cannot go, you do digital stimulation. If you cannot go, you use an enema or a suppository. But you got to get your bowels to move. You got to tell the bowels who is the boss. You need to literally bit the out of it, right? But you do not get up until you know who is the boss. And when you do that 2-3 times, the bowels will understand. As soon as you sit down, it will evacuate, and then you're done for the day, and you won't have that problem. So one of the other things is depression. You know, 30 to 40% of MS patients will have depression. It's not because that they have MS, which is disabling. It's not because of that. It's because it affects, just like it affects your balance, it affects your bladder. It affects the brain, and it does cause significant decrease in the neurotransmitters. And correcting that is very, very important. So I think we have made a lot of progress in understanding the symptoms and getting some of the comprehensive healthcare system to help us manage some of the issues so it makes your life a lot easier and manageable. We talked a little bit about the diet, and the dietitian is very, very important. We have a dietitian that works with us. And a lot of the times, the patients will ask me, Dr. Khatri, what about the diet? What should I do when I have MS? And I tell them that, you don't have to follow a specific diet. Just eat a healthy diet. And how many of you here know what a healthy diet looks like? Raise your hands. Okay, good. So everybody knows, right? When you have in a plate that doesn't look healthy, You want to avoid that, right? So I tell them, first of all, eat healthy diet, right? But there's a couple of things that I would ask them to include in their diet. And one of them is, vitamin D we talked about. We talked about the polyunsaturated fatty acids. That is very, very important as well. So I tell them to take either flaxseed oil, which is plant-based, or take fish oil every day. And I think that's important because how many of you are familiar with Swank's diet? Okay. In Wall's diet, raise your hands. So some of you know about Wall's diet. So Terry Wall's diet or Swank's diet. So Dr. Wall's diet is that of the paleo diet. And Dr. Swank's diet, Dr. Swank did a lot of work. He's passed away. He passed away, I think, at age 100 or something. But when he was like 85 or something, I was doing a paper on alternative therapies for MS. And I tried to, in those days, there's no Google or anything like internet. So somehow I finally got hold of him, and I got him on the phone, and he was in Portland. And I said, Dr. Swank, I'm so-and-so, and I would like to know a little bit about your diet. And he said, oh, great. He says, what do you want to know? And I asked him, and then finally, I said, he was so impressive. I said, I'd like to come and visit with you and learn a little bit from you. He says, yeah, come in anytime, but don't come in spring. I'm going to Europe. And I said, how's your retirement going? And so who says I'm retired? I just finished seeing 20th patient today. And he's 86, right? And he's still seeing patients. And I said, what are you going to Europe for in spring for? He says, I'm chairing a conference on lipids. And I was very impressed. But, there's a lot to be said about. There's a lot of work that's done about the polyunsaturated fatty acids in the diet in MS patients. So I think that's very important. So I think your neurologist is the main person, but there are a lot of other services available. For example, social worker. They play a very important role. MS can cause a lot of psychosocial issues, and we sometimes don't spend enough time with our patients to understand what's going on, because stress can play a very big role in MS. We as physicians, tend to treat you with medications, but sometimes we don't have enough time to sit down and ask, how's your life? How's your family? Because that is very important. Because when you have stress at home, you may not do as well. Stress plays a very important role. It's how your thinking is, how your mind is working, whether you're positive or negative. And I'll tell you a story. So this is a true story from one of my books. I'm also an author. I wrote a book called Healing the Soul that became a bestseller. And then I recently released another book. It's called Healthcare 911, which is about the physician burnout. So in my first book, this is a true story of one of my patients, Chris. And Chris was a young, very vibrant young person. She developed MS, and she had the most terrible kind of MS, relapsing, remitting, but very, very frequent relapses. And despite being on a therapy, injectable therapy, she required frequent IV steroids. And it got to the point where walking from one end of the room to the other was a chore. She would have to hang on to furniture. And that time we were invited to participate in a clinical trial of Tysabri. Now, you're all familiar with Tysabri, right? This is given intravenous once a month. So we were invited to participate in this trial, which is a double-blind, randomized, placebo-controlled trial. So some patients get placebo, some patients get the real drug. But the patients and the doctors don't know. So we asked her, would you participate in this trial? And she said, sure. So she started getting the infusions every month. It's a 2-year trial. 1 year into the trial, she was so much better. She trekked down the Grand Canyon with a 45-pound backpack, and she climbed up again. She started running up to 7 miles. She would do bicycling over the weekend, about 200 miles. And then the unthinkable happened. The drug was pulled off the market because of PML cases. And Chris was devastated. She did not know what to do. She called Biogen and said, and she's a lawyer, she says, I will never sue you. Give me the drug. And of course the Biogen said, no, we can't do that. So she went to the press thinking that the public pressure might persuade them to give them the drug. So in the morning, I open up the newspaper, and the front page is Chris's photo with the backpack. And the title said, "The drug that gave her life is now pulled away from her." That afternoon, we break the code, and she was on placebo all the time. She was not getting the real drug. So I called Chris, and I said, "Chris, I want you to know that you're on placebo." And she was quiet for a while. Then she said, Dr. Khatri, that's the power of positive thinking. Never, ever did she doubt that she was not getting the real drug. And that is so important. We see that time and again. When you have a positive mind, when you're positively thinking, when you have positive energy, it makes a huge difference in how you do. So I think it's very, very important. Try and get rid of all the negative thoughts, negative energy. You don't need that. And I think that's important. The other thing that I've known is that, patients are living longer with MS. The lifespan of MS patient is now same as those who don't have MS. It's just about 2-3 years less. They're leading a good life. And with all the treatments that we have, we need to, as a neurologist, I need to understand what the drug is doing. What is the mechanism of action of the drug? I want to make sure that the patients do not develop any long-term complications from the drug that I'm using. I want to know how this drug is affecting their body, their immune system. I want to know what other complications that can arise. Because this is a disease that is a lifelong disease. The other day I had a patient who is 83 years old, MS patient. And her husband, who came with her, is 87. And after I was done with the exam, I said, "How long have you been married?" And they said, 67 years. And I said, "Well, tell me the secret of your long marriage." And the husband is a very jovial guy. He patted me on the back and he said, "Trust me, Dr. Khatri, you don't want to know." And I said, "No, I do want to know. Tell me." He says, "Okay, listen. It started on a honeymoon. They went to the Grand Canyon. And they went down the Grand Canyon, but they went on mules. And his wife's mule was very naughty, was acting up. And she sat on the mule. Within about 5 minutes, she fell off the mule. And she didn't say anything. She brushed her clothes, and she got on the mule. But before she did that, she looked at the mule and said, "That's number one." And she sat on the mule, went down. 10 minutes later, she fell off again. And again, she's very, very calm about it, brushed her clothes. And before she sat on the mule, she looked at the mule and said, "That's number two." And when she fell the third time, now she's raging mad. She is so mad and angry, she opens her handbag, pulls a gun out, aims at the mule, and shots the mule dead. And the husband said, "Honey, why'd you do that?" And he says, "I was so angry." He says, "You don't kill an animal because of that. That is so crazy. That's so bad." And he said, "I was so mad at her." And after I was done, she calmly looked at me and says, "That's number one." So the other one is keeping up to date and communicating with your healthcare team. The first part, keeping up to date, that is so important. And this is where you go to these meetings like this and you hear about what's happening, what's new in MS, how do your drugs work. Stuart indicated that there are some areas that he went to where the patients were not even aware that there are oral drugs now. So educating yourself is so important because you then know what is out there, what's available. And I think going to the group like this and going to the programs that the pharmaceutical companies organize are very, very helpful because you learn a lot. Granted, when you go to a pharmaceutical companies, you're not going to hear what I say today. I am allowed to talk what I can. But when I am speaking for a particular pharmaceutical company, I need to stick to the slides that are approved by the FDA. I cannot move away. So it's very good to talk about what you really feel strongly about. But even then, when you go to this drug company talks, you learn a lot. You learn a lot about MS. You learn a lot about the drugs. You learn about what the drugs can do for you, the pathophysiology of the disease. So you learn a lot. And I think knowing about what's available, not only the drugs, but the diet, the exercise, the symptomatic management, all of that is very, very important. But not only that, communicating with your doctor is very important, right? As I said, when you go to your doctor's clinic, the visit time is usually 15, 20 minutes. And during that time, the doctor has to listen to you, examine you, review your labs, review your MRI, review your meds, order tests, enter everything, prescribe. Everything has to happen, and then he has to enter everything in the computer. Everything has to happen in about 15, 20 minutes. So there's not much time to communicate. So if you go unprepared, you're not going to get most out of your visit. So I tell my patients, go prepared. Write down one or two things that are very important for you to discuss with the doctor. And then focus on that. Then if you have time, of course, talk about other things. But at least the two important things. And tell the doctor right away or the nurse, these are the two issues you want to discuss. Just the other day I had a patient, I said, Mary, how are you doing? Oh, Dr. Khatri, I'm doing fine. And the husband said, no, honey, but tell him about that you're wetting the bed every night. Oh, yeah, I'm having some bladder issues and everything. I said, how's everything else going? Everything is going fine. And the husband said, what about the mood problems you're having? You kind of, you're chewing me out with every little thing. Tell the doctor about that. Or tell him about the memory issues. Or tell about the spasms. So it took me almost like 6-7 minutes before I finally realized what's going on, right? And that's valuable time that is lost. So communicating appropriately with your doctor is very, very important. Write it down. Or if you're not able to go with the patient or patient has memory issues, send a note if you're a caregiver that please address some of these issues that are of concern. Because I think that's very, very important. And, sometimes communicating not only with your doctor but with your family is also very, very important, how you feel about your MS. And I'll give you an example. One of the nurses in our hospital, she's a tremendous, very, very gifted athlete. And she would do these triathlons and do marathons. And so she would go to these meets. And there she met a young man who, they fell in love, they got married. And soon after the marriage, Sandra was having a lot of issues with fatigue. And to the point where she'll go to work, and after a day's work as a nurse, she will pick up some carry-out foods because she would not have energy to cook when she would get home. So she'll bring the home food, and then got to the point where she would not even have time to clean up. She would just lay everything there and lay on the sofa, and the next thing she knows, she's up in the morning, and then she'll go to work. And it got to the point where the husband thought that now that they're married, she's just being lazy, doesn't want to do anything. So they started getting into fights, and they started having problems. And one day I was sitting on the hospital floor, and I saw her walking, and she was not walking right. She was limping a little bit. And I said, Sandra, what's wrong with your leg? And she sat down and she started crying. I said, Dr. Khatri, there's something wrong with me. I'm so tired. I cannot do anything. I just come here, barely work, and that's it. That's all I can do. And I can fairly finish the day's work. And so I said, let's sit down and talk and examine her. And we got the MRI, and she had MS. And MS was causing her a lot of fatigue. Now, fatigue is something that we don't see, right? If somebody walks into this room with a cane, I know right away that that patient has got some disability. But fatigue is something that we don't see. This is something you experience. And if you don't share that with your family, if you don't share that with your doctor, they're not going to know. And it is so important because it can cause problems. The family members might think that you're lazy, don't want to do anything, but in reality, it's just the fatigue that is such a big issue. So communicating with your team, with your family members, with your caregivers, it is so important to do that. And I think the important thing is that we have so many treatments available. We have so many symptomatic treatments available that MS patients should be able to lead a good life, should be able to achieve all their goals that they want. And that is so, so important. And I think you need to set priorities and goals. You know, when I diagnose a patient with MS, we talk about the treatment plan. We want to start them on a treatment as quickly as possible because the studies have shown that the earlier you start, the quicker you start with your therapy, better the outcomes. And we have learned this from our clinical trials. When we have done double-blind, randomized controlled, placebo-controlled clinical trials, where some patients get the placebo and some patients get the real drug. And usually these are 2-year trials. At the end of the 2 years, when we find that the patients have done better with the real drug, then we switch the placebo patients to the real drug, and we monitor them. They also start to improve, but they never quite catch up with the first group. Okay? So we know that the sooner you start, better the outcome. So I think it's important that we get the treatments going, and the most important thing is that you need to stay on the drug, right? But non-compliance. You know, MS is the commonest cause of neurological disability in young adults in this country. We all know that. But despite that, MS patients may not take the drugs like it is prescribed. Do you know what percentage of the MS patients don't take the drug like it is prescribed? Anybody? Get a free dessert today? It's about 46%. They don't take the drugs like it's prescribed. And the commonest reason cited is, I forget. I forgot to take my pill, or I forgot to take my injection. Forgetting is the commonest cause. Not only in MS, patients with diabetes, with stroke, with seizures, they don't take the medicine like they should. And one of the former Surgeon General said that we have yet to find a drug that is going to work even if you don't take it. And we haven't found the drug yet, right? We're still working on it. But you know, because patients don't take the medicine like it's prescribed, do you know how much it costs this country a year in dollars? Direct and indirect cost, anybody? Want to take a wild guess? It's $259 billion a year. That's how much it costs, because patients don't take the medicine like it is prescribed. That's a big, big amount. So I think taking your medicine is very, very important. And I think we're going to hear from Jeff about the importance of exercise. I only want to say that there's a book called The Spark by John Reddy, and it's an amazing book. You should all read that book. It's called The Spark. It talks about the importance of exercise. And one of the things, you know, my patients talk a lot about, Dr. Khatri, I want to go for stem cell therapy. I want to do this. And I tell them that the best thing that you can do is exercise. When you exercise, you secrete a neurotransmitter in your brain, which is called BDNF. It is called brain-derived neurotrophic factor. And this is like the miracle grow. You know, you throw miracle grow in the plants and they just blossom. It's the same way with BDNF. If you throw it into a petri dish of neurons, they just flourish. So when you exercise, you secrete BDNF, and your brain grows neural stem cells. You know, we were taught in medical school that once your brain dies, it doesn't regenerate. That's not true. It does. You produce neurons by the thousands every day. What you can do is exercise, and that promotes more nerve cells, more neural stem cells in your brain, and you can grow some of your brain back. So it's very, very important. And shared decision is very, very important. I think now there are so many treatments available, and I always invite the patient to participate in the decision making about the drug choices, because they need to feel comfortable with whatever we're going to decide. But as a neurologist, I always tell them that these are my choices based on your clinical presentation, based on your clinical characteristics. Here are the couple of choices. And we talk about that. And then invite the patient to participate. I don't tell them, oh, here's the 14 drugs, go read them and tell me what you want. No, that's not right. We want to tell the patients because we are the ones who know what you're going to do based on your baseline characteristics, based on your MRI. What is the right drug? So I arrive at a couple of decisions, and then we talk. We have a shared decision, and we talk about it. And I think it's very, very important because that way you feel that you're participating in your care. You know why you're taking the drug, the reason why you should continue with the drug, and what is the monitoring that is required to continue with the drug as well. So I'm gonna end my talk here, but let's have a question and answers. I'll be happy to answer any questions, or if you want to raise any points.
Let's first say thank you to Dr. Khatri for coming here.
Thank you.
So who's going to be first? Raise your hand, please.
Two questions. One you can answer quick, I think. Vitamin D, the importance of it. I've heard that you can take too much. Is there a too much?
Sure. So vitamin D, we talked a little bit about that, the importance of vitamin D, and the role it plays in MS. One, it does prevent one from getting MS. It's protective, and also has an effect on the relapses. Now, on the immune cells, you know, MS is an autoimmune disorder, right? The immune cells play a very important role in MS. There are receptors on the immune cells for vitamin D. So vitamin D is important, and there are a lot of studies being done now, and we're learning even more that vitamin D is very important. The way we found out is there was a benefit trial, which is beta-seron trial. Beta-seron is an injectable therapy for MS. And so this was studied in a double-blind fashion in patients with clinically isolated syndrome. So those who were not quite diagnosed with MS, but they had symptoms and MRI findings suggestive of MS. So they wanted to know, if we start beta-seron early, can we prevent a second attack, which would confirm the diagnosis of MS. And so this was a study that was done, and it was a 2-year and then a 3-year study that established that beta-seron prevented the confirmation or delayed the confirmation of MS. So somebody with a very bright idea afterwards, after a number of years, they said, do you have any, pharmaceutical company, do you have any blood samples saved? And they said, we do. So, okay, let's look at the vitamin D level. So they looked at the vitamin D levels on all the patients. And what they found was very interesting. The patients who did not develop the second attack, okay, they had vitamin D level was high. Those who had vitamin D level low, they developed the second attack rather quickly, irrespective whether they were on beta-seron or not. So when this data was presented, somebody in the audience said, well, is it beta-seron then, or is it vitamin D? And I think the correct answer is that it's both, probably. So vitamin D has been shown in many, many trials to be efficacious in both ways. So your other question is, can you take too much vitamin D? Luckily, we have levels now that we can follow. And it's very, very easy to do. It's a simple blood test. And we try to keep the level at about 70 or 80. And with anything, you can take any medicine, you can take too much of it. But you can monitor, and you can do the drug levels. So in my clinic, we do patients every 6 months, we will do a vitamin D level to make sure it's okay. All right.
Great. Next question's here.
I have two things. Number one, you were talking about children that should take vitamin D and how much they should take, and I didn't quite hear how much, and the ages.
Yeah, so vitamin D for children, I usually ask them to speak to the pediatrician, okay? But they can take vitamin D, and the pediatrician would advise how much. But they can easily take at the first year. They can start taking vitamin D. It comes in drops. But the pediatrician would advise. After the age of 17, taking about 4,000 units every day, vitamin D3, is quite routine. 4,000 international units, and it's vitamin D3, right?
Okay, my other thing is, I guess I'd like either this group or somebody to work on. I'm very frustrated. My internist retired a few years ago. And the gentleman that I have now is a very nice doctor and very nice and everything, but he really doesn't have a clue about MS. I mean, I might have an ache and pain or something, he'll say, oh, see MS. And I really think that every clinic should at least have one internist that knows something about MS or have programs to inform them about what is and what isn't. It's like diabetics. No matter what you die of, it's because you're diabetic. So I find that annoying, and I would like something to happen about it, but I don't know what to do about that.
I think you said it well. I think it's important to have that. Yeah. I see a lot of patients who the internist will say, talk to your neurologist. It's MS related. And when we need to realize that having MS does not make you immune to having other conditions. And there could be a lot of issues that may arise. Pre-morbid and morbidity is quite common in MS related to other conditions. They can have migraine, they can have cardiac issues, can have diabetes, a lot of other things that can, thyroid issues, all of those things can occur. Yeah, everything. Sure. No, I think you make a very valid point. Thank you.
Next question.
If you've not been diagnosed with MS, but you have a sibling with MS, should you have your vitamin D level tested, or do you just take the 4,000 milligrams of vitamin D a day?
No, I think I would advise you to get your vitamin D level tested, because the level could be very low, and we may need to treat at much higher dose than 4,000. 4,000 is a maintenance dose. So once you get your level at about 60, 70, then we use 4,000 to keep you going. It's very, very important to get your level tested, because it's like if you're in an empty tank, right, and you're driving your car, you could fill up the whole tank, and that would be good, then you're set, rather than putting in a gallon or every day. So it's sort of the same thing, you just raise the level, and then you put a maintenance therapy, right?
Any other questions out here? Okay, great. Before I let him, I'm going to ask you, what kind of biomarkers are out there these days? Yeah, sure.
So Stuart raised a very important point, and that is the biomarker. And what we mean by biomarker is something that would tell us, an indicator as to how the disease is progressing. So like diabetes, we have blood glucose, right? Hemoglobin A1C, and we can monitor that, and we can treat the patients appropriately and effectively. But for MS, we don't have that. The closest we have is the MRI scan. An MRI scan will tell us how they're doing, but let's face it, we don't do MRI scan that frequently, although it is recommended that we do that every year. But as I indicated, the patient I had this morning, he said, can't afford. And even though there are organizations that can help, still some of the patients cannot. They have a huge deductible on the insurance. But MRI is a good biomarker right now. There's a lot of studies being done to find out what would be a good and a sensitive biomarker. And I think that's very important. That's where most of the research is going. I'm heading to Berlin this Thursday. That's one of the biggest MS meeting in the world. We have it every year. And we're going to hear a lot about these biomarkers at this meeting.
Next question.
You talked about predicting progress. Is there a difference in predicting and or the markers you use between relapsing and primary progressive?
Right. So I think most of the work that we have seen that is used for prognostic features is related to the relapsing form, not for the progressive. Relapsing remitting, 85% of the patients present, MS patients present at relapsing remitting, 15% present as progressive. So the prognostic criteria that have been developed, they're more focused with the relapsing. Right.
Yeah. My question is twofold. First, you mentioned that in rural areas, there are a number of people who are still not even aware of there being oral medication. So if they don't have the resources like we have right here, for instance, how would they know if their own neurologist or their own physician is unaware of the fact that there's oral medications? Isn't that more the responsibility of the physicians to be on top of it? And then the second part of that question is, you mentioned vitamin D levels and start children young if there's a relative with MS. If the physician of these children is unaware of this fact, how would they know what vitamin D levels a small child should take?
Okay. So let me answer the last question first, and that is about the vitamin D for the children. There's a lot of written about it on the internet. If you call my office, we have a nice handout that you can take it to your pediatrician. And I think you're right. They may not know about it. But, as MS, you sometimes need to be your own advocate and take the flyer or information to your pediatrician and ask them that, they evaluate your children or siblings to put them on medications appropriately. As far as the first question, and I think Stuart may have some idea, but you're absolutely right. I think the neurologists need to convey what's out there and what can be done. The education is... So I'll give you an example. I saw a patient in the clinic who was diagnosed 3 years before that. She had given birth to a daughter, and that was her first, soon after that, 2-3 days later, she had optic neuritis and numbness and weakness on one side of the body. The MRI showed multiple lesions in the brain and in the spinal cord, and the diagnosis of MS was made. The patient was treated with steroids, and she got better. 6 months later, she had another attack, and she was treated. Her MRI was worse. She was treated with steroids, and she got better. A year later, her daughter is now running around, and she finds it difficult to catch up with the daughter. She's having difficulty walking. Cognitively, she's deteriorating. So now she decided to come to our center, and we saw her. And I went through her records, and I did not see any drug therapy, preventive drug therapy. And I asked her, I said, have you been on any injectables or oral therapies or IV therapies? And she said, no. So I know the neurologist who treated her. And I called him and I said, and he's a great neurologist. He's very, very compassionate. And I said, I'm just curious. I'm seeing your patient. Why didn't you start the patient on the drug? And he said, Bhupen, she only had 2 attacks. Why would I want to start somebody on this? So, I asked him, I said, don't you have doctors, neurologists, or specialists coming to your office? We have this lunch hour talks to come and talk to you. And he says, we're not allowed to do that. I said, don't you go to the talks in the evening when a specialist comes into the town? And he said, we're not allowed to do that either. So here's a neurologist who's a general neurologist. Nowadays, he goes home at about 6:30 because they have to finish all the electronic work, answer all the calls, do everything. They go home at 6:30, they have dinner, spend some time with the patient, then they fire up the computer again to finish off the work. They sleep at 10:30 or 11, they go in the morning, it's the same thing. The journals pile up. When they're going to find time to read about Parkinson's, when they're going to find time to read about MS, when they're going to find time to read about strokes. The healthcare crisis, and that's what I've written in my book, it's a major issue. And so neurologists should be, but this day and age, it is very difficult to catch up. They don't even catch up with their day-to-day work because the administrators tell them, you have to see 30 patients a day. You have to finish off the chart. If you don't do that, we're not going to pay you. Then we have a lot of other things to deal with. So I'm not finding excusing, but I'm telling you what the situation is right now, and I think that has to change. But you're right. The neurologists need to, and I do travel and I do talk to physicians, and sometimes I'm surprised. They learn so much from 1 hour that I spend with them as to what's out there and what's available. And that helps the patients. So those times when they had the injectables, this was freely available. Then this came the Sunshine Act. And it has really put very, very a lot of restrictions on the doctors, what they can do. So it's a lot of factors. So I'm sorry I give you a long answer to a short question that you asked, but that's where we are. That's where we are. Yeah.
So the question going even further, though, is that there are, you're asking about people in rural America. There is rural America that could be 20 miles outside of this town, and you'll say that that's rural. But there are regions of this country that are extremely remote rural that, I fly back and forth across the country, and you can look down over certain areas out of the airplane, and you see thousands of square miles of windmills going. That's what's bringing power to a town. Or you go to other areas, and you see what looks like football fields, one after another, half square miles, 1 miles of solar panels that are bringing power to an area. Those people are on dial-up. And not most of them are getting power to even enough to be on the internet, or don't even have computers to be on the internet to find out what's going on, all right? And they're in towns with a general neurologist that has got too much on his plate already, like the doctor is saying, about all these other things that he's handling, and he or she doesn't have time to go to conferences to learn more. And that's something of why we, as MS Views and News, want to start bringing some of these programs to those areas of the United States. So hopefully we can educate a few people, and hopefully we could get some neurologists to listen to what we have to say and know that they have to do a little bit more. Okay. Next question.
Hi, Doctor.
Hi.
Thank you for coming here today.
Okay.
I have actually 2 questions. One is based...
How come everybody has 2 questions? Everybody from the get-go has been 2 questions. Okay, let's go ahead. All right, go ahead.
I'm very profoundly ignorant,
No,
and I
answer.
need to
I
learn.
was just kidding. I was just kidding.
The first question deals with research, and the second would deal with diet. The first question, in terms of research, as it applies to vitamin D in general. And I ask the question because if we were in San Antonio right now, and you were giving this presentation, the diagnosis rate per person would vary pretty drastically between the diagnosis in Milwaukee. Okay, so the question revolves around vitamin D that is obtained epidurally versus vitamin D that's taken artificially with a capsule, since it's very difficult to get it in our natural diets. Has there been any research that looks at the effect on the human body of getting sunshine vitamin D3 epidurally versus taking capsules? For instance, if I go out and I cut my lawn in my Speedo, which no one wants to see, but after an hour, seriously, I'm getting 15 to 25 international units epidurally. On the same token, November through February, I take 10,000 international units of vitamin D3 temporarily because I'm getting no sunshine.
No, I think you said it very well. And to your point, MS in Wisconsin is about 5 to 6 times more than it is in the southern states. And you raise a very important point, and that is, why is that? Is it because of vitamin D? Is it because genetics? We do know that people who are born within the tropics, the incidence of MS is extremely, extremely low. But people who are born in the temperate zones, there's a higher incidence of MS. But we also know that somebody who is born within the tropics, but they move to a temperate zone before the age of 14, then they carry the same risk as the area they come from. But if they move after the age of 14, then they carry the same risk of, I'm saying the other way around. So after the age of 14, they carry the same risk as the area they come from. Before the age of 14, it's the same rate as the area they move into. So if somebody moves under the age of 14, say from the equator to the temperate zone, they carry the same risk as the area they move into. But if they move after the age of 14, they carry the same risk as the area they come from. So there's something in the early age that determines, right? So now to throw into all this, I was born and raised in Kenya. I'm a third generation Kenyan, but I'm of Indian ancestry. Now, neighboring country, Uganda, there are a lot of Indians. And the incidence of MS is 0. When Idi Amin came into power, and now, I don't know if anybody remembers Idi Amin, but when he came into power, he kicked all the Indians out. And most of them went to the European countries as refugees. The second generation of these Indians, the incidence of MS was the same as the area they moved into. Okay? So even though it is genetics, in Uganda we didn't see that much. But when they moved into the European countries, we started seeing MS. Your question and your point about natural vitamin D that you get through the sun and your skin and taking it orally, in Wisconsin, as you pointed out, somebody has to go naked in the backyard in 1 hour to get enough sunlight, to get enough vitamin D, and you don't want to do that. And so it's very, very easy to take the oral. And there's a lot of studies done to show that with oral vitamin D, it's just as effective in reducing the relapse rates in patients. So it's important. Yeah. What's your second question?
Nutritionally, even though I don't have MS, I've noticed in people that I know that if you take extra supplements of magnesium, especially magnesium not citrate, but magnesium malate. Magnesium is a great antispasmodic for muscles, and it affects nerve function and blood pressure. And it's very difficult to get it even in a healthy organic diet. And on the flip side of that, gluten. There are people that appear to be very sensitive to gluten. Sometimes it's very obvious from physical, but gluten can have a whole host of mental effects. And I was just wondering if you could shed some light on either of those.
Sure. So, let me say diet is very important. What you put in your gut is very important. Because your gut, 75% of your immune system is in the gut. The gut has a lot of microbiomes, and the number of microbiomes in your gut are more than the number of cells in your body. And these microbiomes in your gut are in direct contact with your immune system, and they also secrete a lot of chemicals which get into the brain and get into other organs as well. So there's a lot of work being done about the microbiome. And so what you put in your gut, the food that you put in, it makes a big difference. And so if you take stools or fecal material from a patient who's having an active disease, the microbiomes that we know, they are very, very pro-inflammatory. If you take stools from somebody who's not having an attack, the microbiomes are very anti-inflammatory. So now we're doing a lot of research with the fecal, so what we call the fecal transplant. There's a lot of power in your poop, if you can say that. And so I think the whole, it's very difficult, if you're allergic to gluten, should you avoid that? Yeah. If you're not allergic to it, probably not. But I think eating sensibly and keeping in mind what you're putting in the gut, how is that going to interact with your microbiomes? Like always, we in the biblical times, the Bible says, right? You are what you eat. And that's true. So it's very, very important to kind of analyze what you're going to put in your gut, because ultimately that's going to affect the rest of your system and your brain as well.
We have time for just 2 more questions, okay?
All right.
This is really short. So you talked about how the first generation of these people that had to move, there was no incidence of MS, but when they moved to another place, the second generation in that environment had MS. Wouldn't that indicate that it's really very much related to environmental issues?
I think what it tells us that it's multifactorial. There's genetic, if you have the genes, and if you're exposed to the right environmental factors, then you may develop MS. So it's multifactorial. That's why it's very difficult to find the cause of MS. Because there's so many different factors that lead up to the diagnosis. It's a genetic, it's environmental, it's a lot of other factors. Exposed to the bacteria, exposed to the virus, a lot of different things, right?
They once said that people closest to the equator didn't get MS, but in Puerto Rico alone, over 6,000 people live with multiple sclerosis.
Yeah, it is. And again, like India, where I went to medical school, we didn't see MS. And now we see a lot of MS. And why is that? People travel a lot. They travel. The international travel has become so common. And most of the Indians that we see MS, majority of them are people who are in IT technology, and they travel a lot. Does that have something to do with it? Is it the infection? It's very difficult to say, because it's multifactorial. But we're seeing MS throughout the world now. There's alone in India, there's about 4,000 MS patients, which we never used to see, which is quite high. Yeah.
All right. Thank you for that. Last question, okay?
Along with vitamin D, Are there other supplements as far as that you suggest for memory or other things to go along with the symptoms or that you have with MS?
Right, so I think, not specifically, but I think the polyunsaturated fatty acids, they are very important, like flaxseed oil or fish oil that you consume. One of the things that, a lot of my patients, when you give them vitamin D, their level doesn't go up. They have to take a lot. And we do know vitamin D is fat soluble. So I tell them to take it with some fatty acids or cod liver oil or flaxseed oil, so you absorb faster. But I think those play an important role because myelin is essentially a lot of fats in there, a lot of fatty acids. And so the last thing that I want to tell, and I'm going to end here, but you need to enjoy your life too. Don't be gung-ho and say, okay, don't be fixated. This is all I'm going to eat. This is how I'm going to eat for my MS. And I've seen this time and again. People just go to the extreme end, and if they cannot achieve that, they become very, very stressful. And some of these diets are very difficult to follow. And one of the doctors from California, who is an MS expert, came to Wisconsin, and she was asked to talk about the diet, and she said, avoid dairy, don't take too much cheese, don't take this, don't take that. And finally, I had to stand up and I said, with all due respect, you're talking to people in the dairy state. You can't tell them not to eat dairy. And the point I said is that, you eat everything in moderation. If you feel like eating ice cream, take a couple of spoonfuls and you're done. But don't just get anal about it and say, oh, I'm not gonna touch ice cream. But that itself creates a lot of stress, and that's not good for you. So have a little bit of ice cream here and there. Enjoy your cheese if you like here and there. But don't say, no, I'm going to completely shut this out, because that's not good. Because if that's what you love, you enjoy it, because life is all about enjoyment as well, right? So thank you very much. I had a great time with you guys.
Thank you.